Hello, everyone. Thank you for joining today's webinar, an Oasis for Maternal Health Outcomes, best practices for using telehealth and other digital tools to virtually address maternity care deserts and SDoH needs. This webinar is sponsored by Wildflower Health. Wildflower is a technology and services company that is transforming care delivery and payment models in women's health to radically improve outcomes. Wildflower offers a modular suite of software, support and services, meeting providers and payers where they are in their journey to value. Wildflower is also the architect of the industry's most comprehensive bundle for value-based maternity care, with pre-built functionality for all actuarial, clinical, and operational needs. Wildflower can help you successfully address the key drivers of women's health outcomes while building a better future for you and the families you serve. Wildflower is ushering in a new era of women's health. Learn more at wildflowerhealth.com. I'm Sean Edwards from the Healthcare Innovation Company. I'll be introducing our webinar today. Just a couple of quick announcements before we get started. Due to the number of attendees, participant lines are muted. However, if you'd like to submit a question for our speakers, please do so using the Ask a Question box that you see on your screen. We'll answer all questions that we have time to address during our session today. Also, please note that the webinar is being recorded and you'll receive an email with a link to the video so that you can view it again. I'd now like to introduce our moderator for today. Leah Sparks is the founder and CEO of Wildflower Health. We are pleased to have her here. Leah, welcome. Without further ado, I'm going to turn things over to you.
Great. Thank you, Sean. And thank you so much for everyone who's joined us to talk about what is really an important and a topic that really needs to be highlighted for maternal health in terms of improving outcomes, cost, safety, and quality. And I am so delighted to have a stellar group of panelists here with us today, who I'm going to now introduce, and we'll create a little context. We're going to have a really fun conversation. And again, thank you for joining and listening in. So the first panelist I'll introduce is Erin Kenyon. Erin is background is in training as a nurse. She is currently the supervisor for Expecting the Best program for Baylor Scott and White Health Plan. And I can say that we have worked with a lot of health plans and Medicaid that run care management programs for maternity. And folks like Erin and her team of nurses are often the people who understand the most the nuance of their members. They are committed to improving quality and outcomes for their members in maternity and in newborn care. And so she has a very unique perspective that we're just excited to hear about today as we unpack this topic. The second panelist introduced is Dr. Sina Harry. He is the CEO of Ouma Health. Ouma Health is a telehealth company focused on total maternity health. They provide telehealth for MFM, behavioral health, lactation. They work with both commercial and Medicaid populations. And Sina himself is just a thought leader, has worked with populations all over the country, and just has great insights to share on this topic. And last but not least, we're so excited to have Ronnie Jenkins, who is the Vice President of Mission Operations at the March of Dimes. Hopefully everyone on the call knows March of Dimes as really the leading nonprofit organization focused on health and safety for moms and babies. They have, as you may know, done a lot of thought-leading work on exposing this problem of maternity deserts and are really helping to advocate and drive for some very focused solutions. So great panelists, great thought leaders that can help shed light on this topic. And just to set the stage a little bit, as Sean mentioned, Wildflower is a company that has been working for more than 10 years in maternal child health. We are focused on driving care transformation and payment model transformation in this space. And ever since we started, when we launched our first client in 2014, it was for a rural state, the state of Wyoming. And one of the first things we unpacked was this need to support the time, transportation benefits, and connecting these dots to help pregnant patients get care that they needed. And in the 10 years we've been operating, I would argue this, and Ronnie and Sina will weigh in on this with data, in some ways this problem is growing more acute, it's getting worse. And I want to set the stage that we're going to spend time over the next hour talking about the problem and really trying to bring it to life, not just the facts and figures, but how it impacts people and patients and women and their providers on the ground, and sort of tease out some of that detail. We're also going to explore possible solutions, what each of these different panelists and things we're thinking about in terms of solutions to bring to bear to better bridge this gap. And then we're going to talk about how do you make it work practically in terms of funding and really build the sort of ROI and business case, because bridging these gaps will cost something. So we're going to talk about that, but I want to be clear, there's no silver bullet. This is a real hard problem to tackle, but a really important one. So as we're going through the content, please think of questions, things you want us to bring up at the end. We'll save at least 10 minutes at the end for questions. And, although this is a webinar, would love to try to make it as much of a dialogue and as interactive as we can. So, that's my context. So I'm gonna start by talking with Ronnie, and especially again, as I mentioned, Marcia Dimes has done just really great research on this topic. And I would love to, and I know we have some slides we'll go through, but I'd love for you to sort of share a little bit about what you all have learned in the data and the research you've done at Marcia Dimes, and what it really shows.
Yeah, thank you so much, Leah. I'm super happy to be here with you all today. And talking about our maternity care desert report, it was released this past fall, 2022, and what it's showing us is that approximately 2.2 million women of childbearing age in the U.S. live in maternity care deserts, and almost 150,000 babies are affected. And so when we're going one step further and looking at counties with limited access to maternity care, 4.7 million women of childbearing age live within those counties. And so just to, quick level set, when we're talking about maternity care deserts, I'm defining it as a way of counties without a hospital or a birth center offering obstetric care and without any obstetric providers. And so, thinking about, what are those stats attached to this? And we found a 2% increase in counties that are maternity care deserts since our 2020 report. And so you have to think that that's over 1,000 counties. That's about 36% of the counties that have no maternity care. And, shaping around this conversation today, it even found that counties with low access to telehealth were 30% more likely to be maternity care deserts. So we're talking about more than 5 million women of childbearing age are living in areas with no or limited access to maternity care. And this is putting these moms and birthing individuals, our babies, at risk of serious health complications. And then we can take it one step further. And when we think about our providers and we dig deeper, approximately half of all the counties lack a single OB-GYN, and over half lack a certified nurse midwife, leading to access and inequities in certain communities, such as rural communities. And so, again, with the stats we're looking at, it's estimated that fewer than 7% of OB-GYN providers practice in rural areas. And over 2.5 million women of reproductive age live in counties without an obstetric provider, and over 170,000 births occur in these counties alone. And so, like I said, as we continue the conversation today, we really want to consider, as efforts have been made to expand telehealth, unfortunately, we see wide equity gaps in broadband access, which creates additional barriers. And so our most recent maternity care desert report really dug into that and found that 19.5% of U.S. counties had low telehealth access, which needs to be addressed, since utilizing access to telehealth services is proposed to be, one of the ways to eliminate barriers and reduce disparities in access to early prenatal care.
Thank you, Ronnie. And so I think that there's sort of a misperception that I've had at times that I think your research has exposed. There's a perception that the gap here is really with facilities, because everyone knows it's expensive to run and maintain a hospital with delivery facilities. But what your research has really shown is there's just as big a gap in the outpatient care with OB expertise, whether it's low risk or high risk or both, which in theory could be bridged by telehealth, but is not necessarily due to all the issues I think that we'll get into. But is that fair?
Yeah, that's very fair.
And is there anything in your research that you all saw that was sort of the underlying drivers of why this is getting worse, or is it speculative at this point?
I think it's multifactorial. So you have to consider, especially with us coming off of the pandemic as well, there's so many different factors, from insurance barriers, from just burnout and the retention of the workforce, and more. So, when you look at it, obviously we hope that with our upcoming reports, we're able to dig a bit deeper into that. But, it's very multifactorial right now.
Yeah, completely. And speaking of telehealth and additional data points, Sina, I'm going to, if I can call you that, or call you Dr. Harry, I'll call you Sina, that's okay. You go way back. You have some additional data that that we can shed light on to, related to MFM access. I'm going to kind of switch to a couple slides on that. I would love for you to speak to, and then circle back a little bit more on some of the telehealth access. But yeah, what can we learn about access to MFM, which is the specialty, of course, that you're trained in, that you helped supplement oftentimes in your telehealth business.
No, I appreciate it, Leah. So for maternal fetal medicine, again, we're OB-GYNs that do 3 years of additional training in epi, prenatal diagnosis, high-risk pregnancies. We actually worked with the March of Dimes when I was representing the Society for Maternal Fetal Medicine's Health Policy and Advocacy Committee. And the map you're showing right now was a heat map that we did first to show where the geographic distribution of MFMs in the country is. And if you think about it, MFMs come in to support the family practitioner, the midwife, the OBs when there's a high-risk pregnancy. And a lot of these moms, after 32 weeks, have to make a weekly trip to see an MFM, whether it be for ultrasounds, whatever it may be. And not surprising, going from the last set of data that we had about a decade ago to now, it went from 1,300 MFM providers in the country to about 2,100. 96% are still tethered into major metropolitan areas serving big tertiary care centers. And even with the telehealth presence that they have, we do have a map that mimics the maternity deserts in terms of the absence of an MFM provider. And I think what really became realistic for us was to look at the fact that a woman living on an Indian health reservation has to make a minimum 4-hour drive right now in the US to see an MFM. A woman living in the western border of Colorado can't just go over into Utah and see the folks from Intermountain that have a great telehealth presence. She has to drive all the way to Denver because of the rules with Medicaid reimbursements and so forth. And women in North Dakota, South Dakota, Wyoming really are having to drive 3-4 hours, oftentimes bad winter weather and so forth. We took that one step farther. And if you go to the next slide, we asked the folks at the March of Dimes to give us the prematurity data. And when we overlaid that with the MFM presence, which is indicated in the red dots here, we noticed that counties that did not have an MFM presence had a 2-fold increase in the rate of prematurity. We're not here to vilify FPs, OBs, midwives, but the system is strained. These folks are expected to see more patients in less time, maintain the same quality, and that extra helping hand is just what they need, whether it's through telehealth, whether it's a presence. I think that's what the data are showing us, is the fact that, listen, we got to strategically think about other things that are going to balance the playing field. More medical students are going into residencies and subspecialties, not primary care, not general medicine. More folks are shying away from going to rural medicine. We're not letting a lot of advanced practitioners, midwives practice at the top of their license and have some independence. I think these are the strategies from a health policy standpoint that we have to look at to right this trend that we have that's going in the wrong direction.
Yeah, absolutely. And you know, before we shift gears, I would love, Sina, to hear your reaction. I think Ronnie's data around that the counties that arguably need telehealth the most, right? So rural counties that maybe don't have OB specialists could greatly benefit from telehealth. And I get the broadband access. You may not be able to do video, but you yourself at Ouma do a really good job of reaching patients any way you can, right? You'll do old school analog phone calls, fax to providers. And so you can still do telehealth without broadband. What do you think is keeping that from being adopted in these rural counties? Or do you have a hypothesis or something that you think could be remedied there to help bridge that gap?
No, it's an excellent point. We built Ouma with access in mind. So as you know very well, because we have shared patients, is we don't, our video conferencing solution works on a 3G signal. It doesn't require broadband. Our video solution, it's simple link they click on and it goes live on any device because health literacy becomes an issue as well. So we thought about all this stuff. I think the problem we're having right now, one is everybody's fixated on broadband as though broadband's going to fix it. It's not. Why don't you go step by step? Why don't you approve audio only first? Because a lot of these moms, one, they're embarrassed to let you see their house on video. They might be more, willing to be on an audio only visit. Take it one step at a time and don't think that a broadband initiative is going to fix everything in this world. I think a lot of this falls on the shoulders of the legislators. They have to understand what the pain points are and really get granular in terms of how do we solve this one step at a time. And one part about our success is we do direct to consumer. We go to the patient, we take the care to the patient. I think the days of thinking that acute care telemedicine within the hospital having telehealth or a clinic having telehealth, you're still expecting the mom to drive an hour to see you. I think the initiatives have to be aimed at taking the care into the mom's home rather than making them drive. I think that might balance it out a little bit.
That's great. And of course, innovative health plans like our friends at Baylor, Scott and White, I'm going to shift to next, can help encourage this as well. So I want to shift to Erin, who, again, her team spends a lot of time with your members and your patients. And I'd love to, we were talking a lot about providers, I was hoping you might have any insights or things you would share about what you see in your member population and how the fact that you have these gaps in care really affect members, and anything you can share to sort of bring that to life would be awesome, Erin.
Absolutely. We're working with moms in big maternity desert areas also, where a minimum of distance is 120 miles at minimum for them to get to their care. And distance isn't the only barrier keeping them from getting there. A lot of times they have other children they have to care for. We have specifically a big refugee population where they have significant language barriers in addition to other children to care for, and this need to travel for care. And we're not just talking pregnancy, we're also talking after delivery. If their baby is in a high-level NICU that's in a big metroplex area, they're not able to be there with their babies. So finding ways to prevent the need for that high-level NICU care. This telehealth during their pregnancy is such a huge opportunity to treat them well during their pregnancy. They don't have to travel. They don't have to find childcare. They don't have to find resolutions for all of these barriers that they're faced with. They can get the care in their own home, be able to see an MFM provider that works with the OB provider or whoever is available close, and prevent the need for all of the other extensive travel and things to get to higher level care. And we see this far too often, far too frequently with our member population.
And Erin, is it fair to say, like, you and your team working with these members telephonically, so you can reach them all over, presumably, as long as you have a good phone number? I mean, are you all doing things, having to do things like pretty brass tacks, like knowing based on where someone lives, you need to drive 4 hours to deliver? Like, how brass tacks do you find yourself needing to be with these members, and how does that kind of feel for you and your team and them? And, yeah.
Sometimes it's hard. It takes a lot of time and a lot of coordination to find all of the answers for these members and make sure that we meet all of the barriers, that we address all of the barriers. It's very widespread throughout our population, and a very common problem. I would say it's probably one of our biggest issues that we address from a case management perspective.
Yeah, definitely. So before we move on to kind of talking about hopefully some ideas for solving the challenges, again, I personally love kind of dispelling what are sometimes misconceptions or myths. And we sort of are beginning to dispel one here that maybe broadband isn't the only barrier to solving this problem, which I thought was a great topic. The other thing I wanted to bring up and maybe get your reaction to, Sina, is another women's health company we were friendly with, Midi Health. They work in menopause. I was speaking to their medical director recently, and they're doing work in rural Alabama. And she described how she was doing physician education on menopause treatments, and she was surprised to learn, Birmingham versus rural Alabama, where she had done these visits. She said the providers in the rural areas seem to know more about menopause, and not sure why that is. And I guess I just, Sina, you've done a lot of work in rural counties as a telehealth provider. Are there, I think it's easy to say, oh, these poor providers in rural counties, they're overwhelmed, they may not know what they're doing. But are there things that, we want to also applaud the things that are being done well? And are there things, that you see in rural counties that people may not appreciate that might be, again, misconceptions about the care people get there?
Yeah, it's an excellent point. I think we have to get away from the habit of vilifying people. I think there are some outfits out there that vilify OBs for rising C-section rates, or vilify midwives who are doing, home births or something like that. They don't see the value of doulas per se. I think for me, dealing in rural America, I deal mostly with family practitioners, not OBs per se. And I'll be honest with you, they make my life easy because they have a fundamental understanding of diabetes, hypertension, thyroid disease, thrombophilia. They know what to manage, but it's not fair to expect them to be keeping up to date with the literature as much as an MFM does. For example, glyburide gets pushed down by SMFM and says metformin insulin is the way to go. You can expect them to be reading every practice bulletin that ACOG's putting out, or SMFM. So I think a good model that's going to succeed is to give them the support rather than bash them. To have somebody that's just bird dogging the cases and stepping in and saying, you know what, on this one, this is the better way to go. Or, you know what, Makina's being taken off the market. Don't push 17 OHB so much and all that. I think that collaborative model coming in and just lending support rather than beating them up is going to be the way. But no, I love working with rural providers. The majority of them do understand the physiology. They make your job easier. They just want the support and they're receptive to it. And one of the questions we get asked by Medicaid, by employers, TPAs is, hey, when you come in on this maternity program, do you not get pushback from the OBs or the FPs or the midwives? Are you stepping on their toes? I'm like, no, I'm a subspecialist. They're used to us supporting them, and they more often than not welcome the help that we give them.
Yeah, and it kind of, if you just step back and think about it logically, if you're working in a community with fewer people, we can't afford to have high-end specialists that only are relevant for 5% of the population or 20% or whatever. And so it makes sense that the providers in those communities would have to be generalists to kind of be sustainable. And there's a lot of benefit, right? There's arguably not enough primary care. So many women in urban areas only go see an OB and don't see primary care. So, if we can figure out a way to make these folks a hub and a trusted part of their community and be supported, I think, that's an interesting point. So speaking of, I'm going to move ahead to spending a few minutes talking about, possible solutions and kind of ways we could tackle this challenge. I think maybe Ronnie, I'll start with you. In terms of things, I know that in addition to exposing research about the problem at March of Dimes, you are also advocating for initiatives and policy changes that could help remedy this problem. Can you say a little bit more about some of the things that March of Dimes is sort of advocating for to help address this?
Yeah, there's quite a bit, and like you just said, it's a mix between our advocacy work, the research that we're doing, but then also our programs on the ground in these different communities. And so, one of the things, just to kick it off, is the fact that we were piloting our mobile health units as well to try to help to reach those areas that we're seeing that had that varied access. And then when we're talking about, our advocacy work, really looking at gaining that support for doulas, as Sina was just speaking of too, like what are those additional resources that we can provide in certain areas? So having that doula support, expansion of the Medicaid expansion as well, and just making sure that there's the financial support, especially when we see such a deficit right now, especially over the past couple of years. And so large scope, looking at even our innovation fund to help fund research to identify further disparities that we're seeing and help to solve for those. So, quite a wide span of work that we're trying to do on the ground.
And say more about the mobile health units. Is that literally going into communities with like ultrasound and kind of like I'm imagining the where you get your blood drawn, but it's like for maternity care? Yeah.
Yes, you're spot on. And so we have our March of Dimes branded buses in various communities. I know we have quite a few around and looking to expand as well, but really, bringing the services to those who need it most. And, as was just saying, we needed to bring it to them. And I think that's really important to remember, and yeah, we love our brick and mortars, but how much can we reduce the barriers from transportation that people are facing and more to try to get to where they need to be for care.
Mm-hmm. And then I guess the sort of last question, you mentioned Medicaid expansion and policy work. I mean, that's one of the things that I wonder about is, just even having, reimbursement so that people can do this work. Is that part of the advocacy that you all do with CMS, or how do you think about that at March of Dimes?
Yeah, that's definitely part of the advocacy work as well. And, we know things can look different state by state. But as a whole, yeah, we're really looking at the reimbursement as well and what that breakdown is. And so we're really looking forward to see, what big wins we could have going into this year.
That's great. That's awesome. And so, again, Erin, sort of shifting to you on potential solutions. Can you share sort of philosophically, we talked about this a little bit in terms of, obviously in care management today, you're actively helping these members day to day, but as you see, paths forward, what are the things you see in the future as potential strategies you guys are looking at to help solve this problem?
Yeah, we're trying to work on a lot. We still feel as health plans, a lot of Medicaid MCOs, things like that, still feel very limited in our ability with technology and protecting HIPAA and privacy laws. But we have a lot of things that we are working towards. For us specifically, we have an app that we created with you, with Wildflower, that is available for our members where they can do health risk screenings through an app. They have trackers for blood pressure and for blood sugar if they have diabetes. After delivery, there's trackers available for sleep and feeding schedules and diaper changes for the babies. Also have the ability to access an extensive library of education on disease-specific things. So we are really pushing and promoting that for our members. We also have MD Live that we use for maternal mental health, where they have access to telehealth visits with a psychiatrist. We have a company we coordinate with to treat nausea, vomiting, gestational diabetes, hypertension, where they just have an app and everything, their glucometer or their blood pressure cuff, all connects to an app and sends information to their OB providers. So that is great for our rural health and our population in the rural areas. With other things where we kind of have limited use of technology, we've utilized a service with Pop-Up Pals that is available even in those rural areas where they have someone to help with things like just companionship and transportation to the pharmacy and just kind of in-home support for pregnant members and new moms. So we're working on lots of things. And we're also in the process of coordinating with doulas, like has been mentioned already, where doulas need some extra support. So we as the health plan are trying to coordinate with doulas and offer them some additional support. So lots of things coming where we do feel like we are still limited. We're trying to find ways around those limitations and grow in our abilities using technology for our members and just trying to find ways to supplement what they have where they are.
Mm-hmm. That's awesome. And so it's back to, I'd like to sort of address this to both Sina and Aaron. So that's interesting about MD Live. That's good to know that, the behavioral health is there. Obviously that's not going to do the OB care, but, as you think about the telehealth solutions or even sort of targeted care innovation like Pop-Up Health, like if you think about telehealth and care innovation, pushing to these rural communities, I know you've done a lot of this at Ouma, like what is working, what's not working as we think about particularly pushing in care access, whether it's through telehealth or other means? Either one of you guys. Go ahead.
Yeah, Aaron, do you want to go first or do you want me to?
Go ahead.
So I think we already touched on the fact that avoiding broadband necessity does help a lot. Another thing that we've had great success with is SMS. And what we do is we give the moms one phone number they can reach out to 24/7, 365. And that SMS is plugged into our Salesforce, which we use as an EHR. So the mom just simply has to text us and have somebody there. And as we talked about maternal mortality, morbidity, we know a lot of them are preventable if they just knew who to reach out to or just had timely access, and that SMS piece makes a big difference for them. So I think that that's one of the strategies that's worked for us. Yeah, I mean, to be honest with you, I think the part that hasn't worked is getting the partner engagement. Sometimes when you go to a health system and you say, hey, this is better for the patients in the community, immediately the question is, well, what is the ROI for me? They're just looking at it from a financial standpoint, not so much what's better for the community per se. And I think that's also a reason behind why a lot of the maternity hospitals are closing in rural areas, because they're not a moneymaker, especially when you have the switch between some commercial that offsets the cost of the Medicaid to a predominantly Medicaid payer mix that's coming in. They just can't float L&D and they just make a financial decision to close it. And it has a huge downstream impact on the patients who have to travel and get care somewhere else.
Yeah. Aaron, anything you would add to that? Any comments on his?
I mean, I love that he mentioned SMS and textability. I mean, that's such a huge thing, especially with younger populations. And that's one of the areas where, as the health plan, we feel very limited because we don't have that textability yet. And are hoping to have it in the near future, but at this time we don't. And we acknowledge, at least case management. I don't know about the population as the health plan as a whole, but we acknowledge that that is a huge barrier for us, and we need the ability to text message our members. So that is a big barrier. And then you mentioned the ROI for something like a health plan. They want to know, how is this going to help us and still be financially beneficial? And that's where it gets really hard for us. and we're, my team, we're the nurses, and we have such a passion for these people. To try to put it into financial data is really difficult. But we're working on it. We're trying. We're doing everything we can.
Yes, and we're going to get to that topic in just a few minutes.
We are.
Yeah. But before we leave kind of opportunities, I mean, I think, one thing that just listening to this conversation, it feels like there's a lot of good tools in our toolbox, right? We've got behavioral health, telehealth, we've got pop-up sites, through March of Dimes, we have telehealth for great providers like Ouma. I think, and again, in full disclosure, in talking with Ouma and Baylor Scott and White in particular as partners, I think, I think one of the things that we're thinking about is, how do we knit this together in a way that is sort of scalable and repeatable, realizing, of course, that like healthcare is extremely local, and it's easy to sort of cast all these rural counties as sort of rinse and repeat, but I'm sure, and we can talk about this a little bit too, there's going to be nuance. But I just wanted to bring up, one slide, and, Sina, maybe you can react to this, or, Aaron, you can weigh in, of like something that we've been toying with as a partnership opportunity as we think about capabilities like what Ouma does with telehealth. Wildflower does obviously technology as well as virtual care coordination. We can do, the blood pressure monitoring and glucose. And we've sort of conceived of this notion of wrapping around, whether it's a family practitioner or PCP, in counties where there isn't, specialized OB care, certainly on high risk care, to sort of make them, again, the hub, and use technology, whether it's text or true apps, and importantly, the telehealth expertise, to sort of hopefully create a model that can be rinsed and repeated, and you could start to hang off of their MD Life or behavioral health or the pop-up health resources. So I just wanted to get, and obviously, Sina, you and I, we've worked on this together, but any reactions or comments on, a kind of a model that sort of creates a prenatal care experience built around sort of a hub of providers in rural America?
I'll take it so Aaron can take a sip of her big, gigantic blue drink. I think the problem is that we all have limitations. My limitation is I reach patients really well, but I can't reach the providers just because of the 50-state coverage and how broad we are. Health plan reaches the provider really well, or the patient really well, but there's gaps in it. And I think for a successful maternity solution, there has to be a triangulation. The payer, the provider, the patient, all of that. And the reason I love this model is that Wildflower helps triangulate that. Basically, the communication back between me and the provider, me and the patient and the provider, and all that stuff. So we know what we do well, which is taking care of the patients and taking care of them. But at the end of the day, we're a physician practice. Our notes are going to go back in a certain manner to the provider. Having the stickiness between the tech stack, between Wildflower and the provider, gives me an easier avenue of communication back and forth, and also to intervene. So they don't have to go through the regular referral channels to get a hold of somebody at Ouma. They can come through that same ecosystem and get an immediate answer on a curbside consult, whatever it may be. That's my initial thought on that. That's why I like the model, the way it's coming together.
Yeah, Aaron, any comments from you?
Just more of what y'all said. I mean, the model is great, and if we could just find a way to make all of the connections work the way they need to, it meets a lot of our needs.
I think the challenge, of course, is, and again, you would love reactions to this, and Ronnie, you're sort of sitting as sort of the, like, you see the global view. I think, to do something like this, which is why I love this panel, by the way, is, in order to really solve these things, we have to, like so much of healthcare, have collaboration across health plans, maybe the state, if there's state things that go on in this for Medicaid, providers on the ground, and innovators, right? People who are trying to help solve these problems. And I think it's just some of those logistics are part of the reality. Any thoughts on that, Ronnie? Would you agree that it's complex?
Yeah, I'll say I wholeheartedly agree. It is very complex, but I think that I think about like the folks on this webinar, getting the right minds together. I think certain components can be solved for. It's really about the openness of what are we doing to really identify those gaps and barriers, and what are we truly able to do to impact those. And so, yeah, I mean, I agree. It's a very complicated component.
And back to this notion, and I don't know if any of you have comments on this, but it just kind of occurred to me as we were talking. Again, if there's anything I've learned in 20 years of healthcare, like it is hyper local, right? And so there's no one size fits all, which is why at Wildflower we talk a lot about configurability. Like we configure everything to have knobs you can turn. But do you all have any case studies or things you've seen that sort of bring to life the fact that rural communities are different or have different needs? Anyone have any insights into that you would want to share? I know, Aaron, when we talked about your plan, you've got sort of members clustered at the border, in South Texas, that are probably maybe different than those who are in Central Texas. I don't know if you have seen any difference in the needs of providers and patients based on, even in the same state, there just being different needs and things that we need to keep in mind as we bring together solutions.
Yeah, there's absolutely different needs in the different areas. And when we're talking Texas is huge, and we're so much bigger than many of the other states. So the needs in South Texas versus Central Texas versus up in the Panhandle are very significantly different. So it's definitely not a cookie cutter solution to meet the needs of the whole state. And so we do have to find somewhere that we can have that configurability, and it's all about making the right connections and trying to find all of the answers, and trying to take it a little bit at a time, one area at a time maybe, or one person focusing on each different area, to try to find all the right answers.
Cool. Any other comments for you? Go ahead, Sina. Yeah, go ahead.
Yeah, no, Aaron and I were comparing our Texas notes before the call. I'll bring up the example of South Texas. I mean, we take care of a fair number of patients because of our employer presence in South Texas. And there's been multiple instances where you had patients that were, a family member was undocumented, or they were undocumented themselves, and they needed to go for a higher level care, but they were afraid of traveling because of the border checkpoints and getting detained and all that. And that's a situation that's challenging medicine wise. You have to come in, give them the subspecialty care without the other subspecialists available, and keep the care local and not have them do the travel. That factors into it. I think the Roe decision definitely changed it. I mean, some of us that do telemedicine have a cheat sheet. If I see a patient in this state, this is what I can talk about. This is what I can offer. The last part of it is, 3% of pregnancies are going to be faced with a fetal abnormality. And some of those, God forbid, will be surgical in nature. And knowing what regionality they live in, where they can go for a center of excellence for care, that care navigation is something we get pulled into as well. So there's a lot of aspects of maternal care, including the fetal part, that impact what region the mom's located in.
So I think the takeaway for folks tuning into this webinar is, if you're looking to solve this gap, making sure you really, obviously you really understand all the nuance, and candidly, as a venture-backed company myself, I've heard sort of, whether it's the venture community or large incumbents, whether it's health systems or more commonly health plans, sort of lament the fact that there aren't, companies that are generally solely focused on solving rural America's problems. And it is something that I think, and we'll move to this next, is, it's not one of those, we'll just do the same thing for everybody. It's not like, in business parlance, a scalable solution, but it's just so important and so much opportunity. So switching gears, and especially given the numbers that Ronnie cited in terms of how many people are impacted by this, kind of moving ahead to, from there's clearly a problem, we've got ideas for solutions, we have to be thoughtful about them, but everything takes resources, right? And so how do we fund and make the business case for this? And Aaron, you sort of alluded to this a little bit. And, again, in sort of full disclosure, Wildflower is very focused on value-based care. I, really believe that if you can find, the wonderful thing about healthcare is that often the problems that are most acute often also create a cost burden for the system. So if you can figure out how to economically mirror those up, you can create that business case. You can create ways to figure out the funding. And so One of the things I know we've done in partnership with Aaron's plan, the Baylor Scott and White Health plan, is look at some of the data on disparate costs and outcomes in there, because you all have both rural populations and urban populations, and kind of to high level takeaways we see in the data. 10% higher claims costs for moms in rural areas and 15% higher C-sections, which, Seeing, I'd love to get your hypothesis on why that's the case. I have my own, but the point is, and there's many more data points we could, and I'm sure, Ronnie, you have some of these at March of Dimes, but, if we can begin to show, look, this is certainly something that is philanthropic and the right thing to do for rural America, but also something we can sort of fund in the healthcare system by bridging these gaps. How do we go about, I would love to hear from all of you, how do we go about thinking about that? And how do we begin to put that together? And sort of any reactions to or thoughts on how we put together that resourcing case from my illustrative panel? Who wants to start? I love economics. I'll talk about it all day long. But
I'll say economics is not my forte for sure. I am a nurse, 100%. But, I can say when we're talking about the health plan and showing this, we can show them potentials all day long. We can come up with all this data to show a need for change, but how do we prove that the change is going to be effective? And where we turn is we start with very small populations, and we have a pilot program. So we'll look at, okay, right now we're going to take this one county where we've seen a higher need, and we're going to implement the change through just a pilot program. And it may take us 2 years to be able to come up with some good data and results, but then we show that and say, this is what happened in this small population in this one county. Now can we expand it to 10 counties and then show more data there, and then we eventually can expand it statewide for us. I mean, and that's just how we have to start. And we have to start very small and show proof that this is going to work and this is going to give you a return on your investment, and we're going to get there, but we have to start very small in these little pilot programs. But in my 3 years with this health plan, we've done that 3 times. We're currently in our third and biggest of showing this little pilot population that over the last year and a half, we've grown from just 5 people to 55 people, and we're showing the benefits of what we're doing. So we'll just keep pegging away at it like that.
Yeah, I definitely second that, Aaron. I think that the pilot component is so important, especially, you all brought up the return on investment. What's the scalability, right? And what's the scalability of that impact? And we know that, Leah, to speak to what you were saying earlier, healthcare is so localized for that community to see what best fits. And so, finding and being able to serve pilots in populations that vary, so we can truly see, what are those different determinants of health in those areas and how can we better accommodate? I know I saw a comment come in about, is the technology even available? And what local resources may we have to lean on to help promote that? And so when we're looking at, various programs and how to implement, that pilot phase, like I said, is so important to really drive that data, but then also identify additional gaps and solve for those potential pain points in the future. So that way you can, have a solid direction to move forward from.
And the ROI we pitch depends on the client. Like, for example, with the self-funded employers, absenteeism is a big one. We pride ourselves on close to 100% depression screening at every single antepartum visit and postpartum visit, and keeping that employee back at work in time, that has a big impact on it. I do think that the femtech providers need to be less disingenuous about what ROI they're putting out there in terms of, I cut down prematurity by 50%, I cut down C-section by 30%. I think if there's a causality, you can report it, but I don't think we should just be willy-nilly throwing those numbers down there. That's just not fair. And for, there's different ways of, displaying this. Like, for example, Medicaid, we help them with HEDIS, measures gap closure. That definitely has a financial impact, whether it's the star rating, whether it's the bonus that they get. RPM's another one. We do remote patient monitoring for diabetes, hypertension with Wildflower, as well as fetal monitoring. If you take gestational diabetes, hypertension, that's going to comprise about 15% of your population. And if you think about that mom driving to see an MFM or an OB for an ultrasound in person, a 99213 in person, shifting that care over to the patient's house and doing the fetal monitoring, the non-stress test at home, you can really have a delta about 5,000 per pregnancy episode for those. So there's definitely tangible ROIs that we can show depending on who the client is.
Yeah, completely. And I think, I would say as another takeaway from this webinar, and Sina and I know are like-minded on this, innovators like Wildflower, this is what we do. So I'm sort of I'm not trying to be self-congratulatory, but I think innovators need to stand by the value that you create and figure out ways to fund your own services based on, decreasing costs, improving quality, improving HEDIS. And again, that's what we love about the move to value and the opportunity, whether it's like a full move to value with the payment model or even moving vendors and innovators to value in some way. I think, the one thing we need to be aware of that we encounter in maternity care, one challenge to overcome is that, you often don't know the outcomes for 18 months in a population, right? Because you want to get all the way through pregnancy and postpartum. And two, I think, especially if we think about solutions in rural communities, when we're doing value-based care contracts for OB and newborn, we typically want a minimum of 500 births, which might be really hard. That's not really, maybe not be pilot size, certainly not in rural America. So I think there's just a lot of nuance for us to think about. But I think, again, the takeaways are, look to the business case, whether it's, the claims cost, the quality measures, the HEDIS measures, figure out solutions that can be self-sustaining by creating that value and have the innovators be kind of on the hook economically for those value drivers would be, I think, some takeaways here. So we have a ton of questions. I'm going to go ahead and shift to that. Why we now, since we have so many questions, so thank you. I don't even know where to start here. I'll just start at the top. Jacqueline Stiff, thank you for your question. This might be one that, Ronnie, you would weigh in on, is whether, and I was wondering this myself, are there grants, are there federal dollars, are there things that could help even, whether it's nonprofits or private entities like those on this call, begin to do some of these initiatives while we look at the data points and proof points? Do you know of any, Ronnie?
I would say right off the top of my head, I feel like I just blanked and I can't think of any right off the top of my head, but I do know that, a lot of legislation, we had a lot of legislation wins at the end of the year that help better support rural areas. And the ones that come to mind are the Maternal Health Quality Improvement Act and the Rural Moms Act that happened, that was part of the Omnibus Appropriations Bill. So that one had a budget that includes like maternal child health and development research programs, newborn screening, health workforce expansion, enhancement of like vaccine access, screening and treatment for mental depression, because, when we're thinking about maternal mental health and substance use stigma as well. So those are some ones that come to mind. The other one that comes to mind too to help further support care in these areas is the Pregnant Workers Fairness Act. I think that was really important, this for any area, quite honestly, but especially with those in rural areas that have more barriers, longer distances to go, et cetera, and more, just provide additional support. So those are some that are just top of mind that kind of speak to that.
Okay, that's great. Alicia Meenan, thank you for your question. She wanted to hear a little bit more, and maybe Sina, you can start here, about RPM and particularly remote fetal monitoring. And the question is sort of, given that these are done by telehealth, how do you make sure that gets back to the primary provider and gets integrated into clinical practice even when done at home? And, we can both speak to this, but why don't you start?
Yeah, no, excellent question. So RPM's been around, and it's been around on the internal medicine side of the business for chronic care management and so forth. OB, it's slow to adopt, not shocking, because as a specialty, we're slow to adopt everything. What we do is a lot of the vendors that do RPM have integrations within the OB's EHR. So that's something you can always look forward to. If that's not possible, then as a physician practice, if we ingest a lot of data, let's say it's from a glucometer, let's say it's from a blood pressure cuff, and we summarize it and render an assessment on the patient and manage them, it's your responsibility on whatever cadence, whether it's once a week or every couple of weeks, to send that information back to the provider. Fetal heart rate monitoring is another one that we do, and on that one, again, you just want to assess the fetal heart tracing, whether it's a category 1, whatever it may be, and push that back. It's a little more challenging than the discussion here, because you have to talk about the integration back to the provider's EHR. If it's not there, then it might be an old school specialist sending a note back to the provider kind of a model. But there's great platforms out there.
Yeah, and again, Wildflower does this, and I do think you're making an excellent point. So when we do RPN, we don't do the fetal monitoring like you do, but because we're an intermediary. But when we don't practice medicine, we have virtual care coordination. Usually in urban areas, when we do RPN, we're sending it back, two-way integration into Epic. And as we think about these other types of providers, I mean, I think we have a similar philosophy that you get it back paper, fax, secure email, like whatever a provider can tolerate. And it has to be highly configurable. It cannot be, there's just probably no way you're doing EHR integration with a bunch of small providers in a rural area. So you have to have extreme flexibility. And this is part of the reason at Wildflower, we have non-clinical staff kind of in between, when we do monitoring, in between patients and the provider, so that they can be monitoring the signals and pick up the phone and call the provider to let them know, because you just can't rely solely. I mean, as I would like to say, technology scales until it doesn't, and when you really need that human component and other forms of communication. So definitely something to be thoughtful about. Thank you for that question. So there was we had a couple of mentions about the impact of doulas. And I think and there's a question from Crystal Richards. Thank you, Crystal, for your question about experience getting states to recognize doulas as a provider entity, or I know there's also a mix in how doulas care is being reimbursed. And so I guess I would love, I think both Ronnie and Aaron mentioned the impact of doulas and supporting that. I would love to hear a little bit more about, how you think doulas can help, and two, anything you're seeing about getting doulas recognized or reimbursed. So any comments or thoughts on that? Because we didn't really delve into it too much.
Do you want to start? Do you want me to start, Aaron?
Go for it, Ronnie.
Oh, so I can jump in. I'll kick it off. So I think that one of the things that's really important is to first remember that, there's different types of doulas. And I think that, for just general public understanding and knowledge, that is something that's not understood. And so first off, just building the awareness surrounding what a doula can do to help support, but also how doulas can help to advocate for the individual, because I think that that's really important, because especially in that patient-provider interaction, there's so many things that people might be coming, to this visit first time, scared, not knowing what's going on, right? And so it's really talking about, what are some additional things and additional supports that can be provided from that doula to better prepare our patients for what they're looking to experience. But then also, through the pregnancy journey and postpartum, especially with the maternal mental health concerns that we have with postpartum, substance use stigma, and more, how can we better support, like I said, the care that we're trying to receive? And I think that doula is a great pathway to that, to help build comfort. And that especially is seen in our Black and Brown populations as well, as far as building trust.
Aaron, anything you would add to that?
Absolutely. Where we are currently trying to bring doulas into as part of the care team is more still in our bigger metro areas right now, but using them to go out into the more rural areas and then come back in and coordinate with our OB and MFM providers in our bigger metro areas. And so we're starting there. And I think, like Ronnie mentioned, they are more able to advocate for the patient and take first-time moms who are scared and have no idea what they're walking into, and educate them and be a support to them and gain their trust, is a huge area of opportunity for us. And that's where we're working to have our doulas go out into the smaller areas and then come back in and coordinate with our OB and MFM in higher populated areas.
And presumably, I know there's a lot of companies that I've seen in working on, faster doula health networks and credentialing. And I mean, you can, I can't create a bunch of MFMs in 1 year, given all the years of training you did, Sina, but like, you can become a doula. That's something you can work in a population, find people with training and credential and support them. So it's sort of, I mean, it's obviously something that needs to be local, but it is a workforce you can begin to bring up faster, presumably, than MDs or nurses, right? So that's another interesting.
There, I think only 8 or 9 states right now reimburse at the Medicaid level. There's only a handful of states that are mandating commercial reimbursement for doulas. I think that reimbursement is going to have a trickle-down impact in terms of more folks wanting to go into this and not just relying on a cash-only option to do this. The tide has turned. I think back when New York was doing the pilot, there was a lot of momentum behind it, but that pilot just went awry for a myriad of reasons and just completely derailed the whole doula movement. But I think the tide is turning. I think there's a lot of support for doula movement again. And I think you're going to see a big upswing in terms of their integration into the system in the upcoming, 5 to 10 years.
Yeah, completely. This is an interesting and maybe a quick question. And I don't know if Ronnie, you all would be the ones to have seen this in your data. From Ling Lu, thank you for the question. This person asked, have you found a trend of OB-GYN providers either leaving practice or just cutting their services down to GYN only? Given that OB is we have high rates of burnout in OB. It's hard, delivering babies, they're all hours. It's a hard specialty to be in. Have you seen any of that in your data, Ronnie?
Yeah, and so that was, one of the things, like I was mentioning earlier, is that we have found a trend that OB providers are leaving the practice. And a lot of times, yes, it could come from site closures and more, but at the same time, what you were just saying, Leah, burnout. That's huge, especially, with the past few years that we've had. And then also legislative changes has caused a shift in where we see providers moving. I can't speak specifically to cutting down on the GYN services. However, like I said, do we see that reduction in force? Yes. And is that causing a huge barrier and only expanding the need? Yes.
Yeah, I think we're going to have like a shortage of 20,000 OBs by 2050. It may be worse than that, but it's definitely getting more acute. We have to figure this out. I think this will be the last question we have time for. Jade Kyle Miles, thank you for your question. I'll just sort of summarize it here. This person is really asking about, I think, agreeing that telehealth and virtual care can really help with access to care and health equity, which we didn't talk about as much, but is really intertwined in this whole conversation. There's different types of health equity, right? It's by race, ethnicity, and quite frankly, where you live is part of what we're exposing here. But this person asks, what do you see in terms of the future of VC funding? And so it's kind of a question for you and me, Sina, in terms of the opportunities for venture capital and private equity to fund this, and especially given how timely it is with the past few days and the weekend news. But I'm happy to speak to this, or you can, Sina, in terms of your thoughts, but I know we're pretty like-minded. You want to dive in, or you want me to start?
I'll defer to you. You take the beating first.
So listen, I think about this a lot. We raised our first venture round in late 2013, seed round, small, and everyone at the time told me women's health is a niche. And I was like, 50% of the population, how is this possible? And that has begun to change. There has been a lot more funding in women's health over the past, particularly 3 or 4 years, which is really welcome to see. I would say we are still just barely scratching the surface on tackling what I think is the most scalable problems in women's health, the real clinical challenges like we're exposing on this call. I think it's easy for venture and private equity, if you're listening in, to kind of go to the things that are like Sina said, it's important to reduce absenteeism for big employers. It's important to get, the sort of commercial plans geared with the right services, and that's important and a part of all of our businesses because it's part of scaling, but we can't ignore the underserved, the health inequities, the stuff we're talking about today, and arguably there's billions of dollars more in opportunity in the real clinical challenges than the things that are sort of maybe nicer to have. I hate that you'd say it, but so I think that there's a huge case to be made, and I love working with Ouma and his team because he is really focused on the hard clinical challenges, and I think that is the funding case to be made. So I'm bullish. I think, you know, a lot of venture capital and private equity are beginning to see that and do that math, but we still have work to do. And I know we have 1 minute left, so any two seconds of comment, Tina?
Yeah, no. I fully agree with you. I think a couple of things. One of it is I think there has to be a better definition of underserved. So when these PNVC folks are looking at it, they don't look at us as, oh my God, these guys are taking care of the rural patients because they're underserved. No, when we deal with Medicaid, like for example, Inland Empire in California, which none of us would ever label as rural, doesn't have enough OB-GYNs. There's 30 weekers, 32 weekers walking around, unable to find an OB to take them. That is an underserved population. When you talk about Texas, where they used to have originating site restrictions, a woman in South Austin couldn't take a bus to North Austin and see me for MFM because I wouldn't be reimbursed because she was in the same geography. So the definition of underserved has to change. I think that's one thing. The second part of it is, I'll speak to telehealth. You did a great job talking about femtech. Telehealth has not even begun. If you ask me what is the future of telehealth, I think we've only scratched like the top 2-3% of it. I think there's a whole world of evolution to come into telehealth. RPM is going to be a critical component of it. And I think whatever model that the VCMP is going to focus on is going to have to be a model that embraces hybrid care, not a pure virtual care. You have to engage the docs and the midwives on the ground to get a better outcome for these patients. You can't just come in cocky thinking your virtual solution is the end all. I think if you do that, then you have a successful model. But I think that they're smart. They're noticing that there's a trend on this side of the business as well.
Awesome. Well, I know we're at time. Thank you so much. Sean, do you want to wrap us here?
Yes, thanks everyone for joining us. Thank you to Wildflower for sponsoring. Just a reminder, everyone, today's webinar has been recorded and you'll receive an email with a link to the video so you can view it again. To get more info on how your organization can speak or sponsor an upcoming webinar, please visit Think360. That's think with a C, think360.com. Thanks again for joining us, everyone. Have a great day. And this now concludes today's discussion.